Afternoon, everyone. And I see people are slowly trickling in. So we'll get started. Welcome to the Behavioral Health Echo. Thank you all for joining us today. I'm Kato, and I will be facilitating today's session. Before we get started, please note that we are recording these sessions for later distribution. Please note that anything listed in the chat does not appear in the recording. These sessions are enabled for live closed captioning. If you would like to view closed captioning for this session, please navigate to the bottom of your Zoom window and select the Show Captions option. You may need to click on the three dots or More menu at the bottom right corner of your Zoom screen to find this option. If you're having trouble accessing captions, please chat Taylor, our Echo IT. To help us with attendance, please enter your name, affiliation, and email into the chat. To access the chat feature, click on the speech bubble icon on navigation bar at the bottom of your window. To all the Be Well Texas providers, please make sure that you identify yourselves during this session by entering your information into the chat, or if you are joining by phone, please email your phone number and name to bewelltexas@utesca.edu. We appreciate your support in helping us capture this on record. And we encourage everyone to join by video for the discussion portion in the latter half of the session. That said, regardless of how you've shown up today, we're just happy that you're here to learn alongside us. And please stay muted unless you're speaking, and we do encourage you to speak. If you've joined by computer, your mute button is on the bottom left of your Zoom controls, or if you are on the phone, just press *6 to unmute. You can also use the emotions menu in the bottom right of your Zoom screen to raise your hand and indicate you have a comment to share. Or you can use the chat to share your perspectives. There are a lot of us in this space, so please keep your comments brief to allow others to share their comments as well. And finally, please note that no protected health information is allowed in either the chat or our discussions. And towards the end of the session, Taylor will send out a link to an evaluation survey. Please fill it out and give us your feedback on how to refine and shape these sessions to address your priorities. And our didactic today is on becoming trauma-informed and will be presented by Dee-Dee. And following that, we will discuss a case presented by Mr. Kolwatz. And we will start with introductions, followed by didactics, announcements, the case presentation, and open discussion. Thank you again for joining us today. And these sessions are what we make of them. We encourage all of you to share your perspectives in today's conversation. And let's get started with introductions. Katie.
Hi, I'm Katie Dondenville. I'm a clinical psychologist and the director of the Strong Start Training Initiative here at UT Health San Antonio. And we focus on training mental health clinicians in evidence-based interventions for trauma, PTSD, and suicide prevention. Happy to be here.
Thank you. Thank you for joining, Katie. Dee-Dee.
Good morning from Southern California. I am in the desert, so that's all the bright lights you see here today. And I'm Dee-Dee Stout. I am in private practice. So I run a caseload seeing individuals, families, and couples with addiction issues, challenges in there. I work in a harm reduction perspective, which means I help people to examine their relationship to a substance or to some other behavior that they'd like to take a look at and then decide what they would like to do about that, if anything. I'm also on faculty at St. Mary's College in Moraga, California, up in the northern part of California, teaching graduate courses on substance use disorder and motivational interviewing in our forensic and what are we calling it now? Forensic and trauma certificate, I believe is the right term. We just started it this past year. Finally, I'm also a trainer, and my expertise in areas of motivational interviewing, in trauma-informed, as well as in harm reduction psychotherapy and solution focus.
Amazing. Thank you, Dee-Dee. And is Cole here? Kolwatz? Not yet. All right. Jasmine?
Hello, everyone. My name is Jasmine Vidal, and I'm the Echo Coordinator for our Behavioral Health Echo. Thank you for joining us today, our last session of the year, and I hope you enjoy our session today.
Thank you so much. Let's move on to our didactics. Taylor, could you share the slides for Dee-Dee? And Dee-Dee, whenever you see the slides, please take it away.
Thanks. So this is our team today. Some are missing, but hopefully will show up yet. Certainly Dennis is hoping to come back. He had a bit of an emergency with a patient. So next slide. And part of what we want to do is facilitate a conversation on becoming trauma informed. No one is completely trauma informed. I mean, that's kind of the point, that we are always working to become better at that. Lisa Najavitz, who many of you, I will assume, but maybe not, know of the curriculum Seeking Safety. It's been around for 25 or 30 years now. I trained with her many, many years ago. And one of the things that she says is they, meaning clients, constantly tell their stories, sometimes even with words. And I'm wondering what that statement might mean to some of you. And if you want to open your mic, you can do that. This is part of our engagement process here, getting you all to talk a bit more about this. And if you'd like to instead put it into the chat box, feel free to do that. I'm kind of curious what will come up. I don't have the chat box in front of me, so if one of you can read any of those statements that come in, I would appreciate that. I'm just doing a split screen here. So maybe health issues. Okay, so I can see some of them popping up. Great, Sandra. That certainly is possible. That is not exactly what she had in mind. But as a health counselor, I would absolutely say that that's going to be part of it. It's going to show up in a lot of different areas. Certainly trauma is going to show up in different places. Anything else? Have a quiet bunch on this Friday so far, huh? Okay. Remember, I'm a professor. I'll call you out.
Oh, sorry, I couldn't figure out how to raise my hand.
That's okay.
So I mean, really, it's the way they present themselves, right? I mean, it's
Yeah.
how they show up or don't. Ugh.
Yeah, exactly. That's exactly what she was talking about then. And I think this is a real challenge in treatment, right? Having worked in inpatient for a very long time and also some other modalities as well in treatment. But this was always one of the challenges. And we did not understand it when I started back in the 80s. What was happening was we would ask people to give up their major coping mechanism, which is usually the substance. Could be behavioral too, though, right? One of the two, before they learn anything else or have anything else in place. So we require that they give that up, and then we wonder why they're acting out. And that might look like sleeping. It might look like physical, yelling or screaming or yelling at staff or threatening or walking out of groups. There's a whole lot of different ways that this can show up. And what we know today is that those behaviors are very much related to giving up this substance. So you could almost think of it as detox in some ways. It's also related to the trauma coming forward. So now that the substance use is calming down, at least being reduced, now that person is likely getting flooded with all kinds of emotions. And again, if their best way of handling those emotions is with a substance, and we've sort of taken that away, then what are they going to do with all of that? Oftentimes they don't have the words for it too. And Katie, I'm wondering, because we were talking about this beforehand, what you would add to that as well.
Yeah, I think one of the experiences when you are a client or a patient is that you're interacting with many different providers and navigators, and oftentimes that information is not efficiently or effectively transmitted. And so when we put on our own patient roles, we can observe how often we are repeating ourselves and reminding people of what's relevant and important to us personally. Yeah.
Yeah, great, thanks. Next slide. Oh, let me get that, there we go. So what is trauma-informed care? And you'll see on the slide, here are some of the things that we talk about. So we want to help people to integrate and appreciate their past and their current experiences of trauma into all aspects of the behavioral healthcare systems. So it means partly that we all have to be talking to one another. There has to be communication between all of the different aspects of treatment, especially if they're not done all in your facility. So, not just having one staff meeting. I mean, we could do that at the hospital. It was great. But when I started working in other areas, so places that didn't have all those different services for mental health or for some other kind of healthcare, maybe dental work that needed to be done, right? We're not going to have a dentist even in the hospital. So we need to all be talking to each other. Our goal needs to be to not re-traumatize individuals. We want to support safety. And here's the important part of that. Safety is how the client defines it. And this gets really tricky, and we'll get to that. We want to promote individual choice. That can also be tricky when you're, especially in a residential setting, when you have some rules that you want everybody to follow. Now, how do you promote individual choice there? And we give those who serve choices in their care. So we need to constantly be checking in with the client around, are they getting the care that they want or need? Is this what they thought treatment would be? Is there something else that we can be doing? What would help them to be engaged more? What would help them, what perhaps they need less of? Oftentimes in treatment, we repeat ourselves a great deal. And we take advantage of groups and of education, videos sometimes. And I've always thought it was interesting that the two things that research has consistently shown that is not helpful for engagement, videos and education groups. And I'm not saying we should stop doing those. I'm just saying we need to keep it in our minds that those aren't really going to help with engagement for most people. Next slide. Trauma-informed care is also very much, oh, you didn't change. Did you change? I'm sorry. I'm looking at my slides instead of at what's up. There we go. Let me come back here. What I showed. Got it. Thank you very much. So more in trauma-informed, sorry, that's what I get for looking at my slides. Acknowledging common connections between substance use disorders and trauma. Okay, and we know this more today. Trauma is not always the reason that people develop less than healthy relationships to substances, but it certainly can be a lot of it. Lisa Najavitz, again, back to her work, she showed 55 to 99% of women who presented to treatment had at least one sexual trauma, and most of them had multiple. We need to recognize that the range of responses, again, here we go. They're not going to show it with words. They are going to show it with behaviors. And here are some of the things that happen. Using, when people get passes, going to support groups, going on medical appointments. People will sometimes use in those pockets of time that they have. Instead of kind of, chastising them for that, instead understanding that's to be expected. We should expect that people are going to do that and to work with that. Appreciating that the trauma often results in challenges. This is going to be part of what happens. One of the things that I learned to do in working with women in prison was to tell them they should not be trusting me. I'm not going to require that they trust me. I need to earn that. And I understood that. I didn't at first. Let me be very clear on that. And I came to understand that. So there were good reasons that the people that we work with don't trust others, especially if they have a trauma background. Next slide. While we're changing slides here, I can also add that trauma-informed care or trauma-informed work also means a change in the culture. It's not about just what we do, but it's how we view clients and patients. Are we seeing them respectfully? Are we understanding that they're human beings? They're just having a tough time right now, and we're probably seeing them in their worst that they've ever been. We also need to be very careful about how we wield power over folks, particularly folks with trauma. Again, this is what trauma informed is about. We don't want to recreate that oppressive nature of the perpetrator, or of, even the substance. You can make an argument, perhaps the substance has some power over that individual, right? So we want to avoid a lot of the power struggles. Part of that is going to be threatening. Part of it is going to be arbitrary rules. One program I worked in had, I believe it was 69 rules, and to move from phase 1 to phase 2, the women had to memorize all of those rules and state them. I remember saying to one of the managers, I had been abstinent for decades at that point, and said, I couldn't do that. And you're asking people who are just out of the real world and in a prison setting and in treatment at the same time to be able to memorize all these things. And what is the treatment purpose of that? Where are you finding that in some modality that's helpful? Obviously, we don't do involuntary medication. Katie, want to add anything else to that?
I'm checking the chat to see if anyone has
Thank
any
you.
comments about that. I wonder, as people are, thinking about what Dee-Dee is sharing, how is that, how are you observing these things within the organizations and practice that you serve?
And perhaps how are you coping with that right now, or not coping with it? Not you personally, but as an organization. What do you see?
Lindsay.
Thanks, Katie. Yeah.
Yeah, so I will say that I work around a lot of organizations and have for quite some time, and I very often see things like a lot of recovery houses require AA attendance, right? Or NA attendance. A lot of times they'll have, and I'm a peer supervisor, right? So, they'll have peers doing like drug testing, which is not ethical for peers, right? So I mean it's like all of these things that are very like mandated that somebody do that might not necessarily be the best thing for that person.
Right. Right. Thank you for that. I mean, one of the things that I did years ago was working here in the state of California with all of our domestic violence shelters, now what we call IPV, interpersonal violence, right? And what I discovered was that they were all doing drug testing. And I said, you're shelters, why are you doing drug testing? And they said, well, we need to know if people are using drugs here. And I said, okay, how come? They're not in lockdown. They can come and go. They can even work during the day and come here at night. I'm really confused. What's going on? And they realized that they had no good reason for doing it. It was a huge cost to them. And it was playing the part of a perpetrator, of an oppressor to women who were in a shelter specifically because they had just gotten out of that situation. So now they had taken on that role, and they had forgotten who they were, if you will, that they should be a no threshold or low threshold facility. And I loved that most of them made that change. When they went to court with some of the women, and one of the courts in Northern California, the judge asked, what are you doing differently? When they informed that judge that all they did was stop drug testing, he was absolutely stunned at the difference in how the women were showing up to court. And I thought, well, there you go. Yeah, these are adults, and we need to treat them like adults. If you really have a suspicion, first thing you should be doing is asking, you look like you've been using today. Tell me a little bit about what's going on. And not, we don't have to go to that drug test for the first thing. Yeah. Hopefully, too, people are realizing that 12-step is not the only way to go. It is a way to go. I found it very useful early on, absolutely. And yet there are many people who don't find it useful. And gratefully, there are a lot of options. It also has been found in the courts, several courts of appeal now in the United States, to be a religious organization. So technically, we can't force people to attend 12-step. We have to make it an option.
Tell that to a judge.
Sorry?
Tell that to a judge.
Well, you can, again, it's in the record. I mean, judges, I guess, can do what they want, but, we have certainly had lawsuits here. I think Texas has had a lawsuit. Florida has had a lawsuit, and all of the people have won their lawsuits. They challenged it. So just keep that in mind. Yeah. There's just no reason. So just give them, say this is an option and maybe something else would be more helpful for you. Yeah. Anything else that came up? Katie, did you see anything else in there? And we'll go to the next slide.
Someone said on the chat, another one I see too far is often recovery houses kick someone out if they fail a UA, no refund, no warning, just throw people into the streets.
Right. We used to, in therapeutic communities, that was called curbing, meaning you put a person literally on the curb, and usually done in the middle of the night. So we'd wake somebody up at 2 o'clock in the morning and throw them out, without their belongings, which again is illegal. You can't do that with a patient. Think waking somebody up in a hospital and going, okay, 3 o'clock in the morning, you're out of here. That would be a lawsuit, right? So those are the kinds of things that have no therapeutic value. So I would ask us to question why we're doing some of these things, and asking ourselves that. It's also clearly not trauma informed, because that is going to be traumatic on a person, no matter who that is, right? Yeah. Next slide, please. And next slide. So we want to look at organizational trauma-informed care. Here are some of the things that we want to look at for an organization, because we've talked about the person now, if you will, sort of the clinical and other staff. Now we want to look at the organization as a whole and say there really needs to be a commitment to being trauma-informed. And it's okay to say we can't do everything that we would like to right now. We're going to take this by bits and pieces. We're going to go slowly. And that's what I encourage organizations to do. Have lots of conversation, maybe even have focus groups of your staff to talk about what some of the problems they see in becoming more trauma informed. And again, that this is always a work in progress. We want to develop an implementation plan. So let's say we decide we're not going to do random UAs for everyone. We're going to leave that to be more specific. That would save a lot of money. And it would also create a more trustful environment. All right. We're going to say we trust you until you show us that we shouldn't trust you, or that there's a good reason. If somebody is falling down the stairs or passing out in the group constantly, okay, there might be a good reason. And you've talked to them and they're not coming forward with using a substance. Then you might say, okay, this would be a good time for us to take a look and see what might show up in your urinalysis, not as a way to punish you, but as a way to better help you. Right? Next slide. Developing a disaster plan. Okay, I think of that as the relapse prevention plan for the organization. So when we as clinicians, when we fall back into our old behaviors, I can tell you the gift that I got from my last patient at the hospital was a riding crop. Whether those leather sticks that jockeys use to get the horse to go faster. The scariest part is that he meant it as a compliment. Those were the days when you beat the crap out of your patient and they went, thank you, that's what I needed. That is not trauma informed. And I still have that sitting on the back of my office. You won't see it because it's kind of hidden on the top of my bookcase, but I have it to remind me who I was. And I was perfectly fine behaving that way for a few years. And then I learned, mostly because it burned me out. You can't fight with people 24/7 and think it's not going to take a toll on you. We want to really create this positive environment so that people will want to be there. Now, not all the time, we understand that, but can we make treatment more enticing? It may not be as enticing as the substance you're using, but let's do better. That's what it comes down to. We also want to increase safety. So when people are happier being where they are, when they're at least willing to try to do something that we're asking them to do, and we've put them in a supportive environment in which to do that, they're less likely to create trouble, right? And to cause problems, if you will. They won't act out. Next slide. Who needs to be trained in trauma-informed care? Absolutely everybody. That includes your board, that includes all management, that includes the person that answers the phone or takes care of social media. I mean, it's every single person that's involved in an organization. Next slide. So let's just walk through a little bit about the principles, and then I'm going to ask for some questions or some comments from you all and from Katie. I'm going to give her back in here. And say the principles of trauma-informed are promoting awareness of trauma and really understanding what that means. By the way, we love that trauma-informed care can be used with everyone. It's not going to harm someone if they don't have trauma. It's okay. We want to recognize that the symptoms or the behaviors that someone is acting out right now are adaptations. That is how they have learned to cope with the trauma. And it's just a coping mechanism gone awry. So we want to look at it in that way. We want to really see things through our clients' eyes, fully enter their world as much as we can to understand why they're doing what they're doing, perhaps better than they understand at the moment. We very much want to reduce, I don't know that we can eliminate, but we can reduce, we can minimize, as it says here, the re-traumatization of clients and patients. This is particularly true for women. Again, back to our statistic that most women that come into treatment have had at least one sexual assault. It's about creating a safer environment as much as we can do for all people, remembering that we cannot create a safe environment for everyone. That is impossible. So stop saying you have a safe environment. Say you have a safer environment and that you're open to discussion. Okay? And lastly, we want to support autonomy, and maybe that should be first. You know, we want to give as much choice and control over people's lives to them as we possibly can. Next slide, and then I'm going to want to open it up here while we go to the next slide. So Cindy, I think most of the time that friction happens due to unrealistic expectations, not trauma-informed. Yeah, it is unrealistic expectations. You know, I've had too many clinicians, and I've been the clinician that expected my patients to be where it was far that I had done. I mean, that's ridiculous and it's insane. I had lots of years to get to where I was, not saying that I was fully healed either. But, you know, to expect that from people who are coming into treatment is really silly. Pat Denning, who's been a big influence on me and a mentor to me for more than 2 decades, and wrote one of the seminal books in practicing harm reduction psychotherapy. And Dr. Denning will say, we expect people to not show the very symptoms that they came into treatment to deal with. You know, that doesn't make any sense. It would be like asking someone who's depressed not to show up depressed. Or someone with schizophrenia say, well, we're not going to treat you until you stop hearing voices. Yeah. Okay, but you're not going to get very many people in that way. And so I think you're right that we have this very high set of expectations, and maybe we think that will make our job easier. I'm not quite sure what's up with that. I'd love to hear more of your thoughts on that. Okay, anything else in here? I think I missed somebody's. Now, oh, thank you, Sandra. Another one I see far too often is recovery houses picking up. Oh, we did that one. Okay. There are 2 more. People who should be providing trauma-informed training should be those impacted by trauma. Maybe. I mean, I don't think you have to be. I think you need to understand trauma very well. You know, if it helps you any, I have full-blown PTSD. Mostly in remission these days, but I'm also neurodivergent. So, you know, it can come up at any time, depending on how sensitive I am at the moment. Let's see, what else do we have here? meaning there's still this thought and practice of if a person's receiving treatment, that automatically means that they will be or need to be abstinent. Absolutely. I mean, abstinent is great for some folks, and it actually can make things worse, like PTSD. Lisa Javits, again, talks about that very well and says, that when people are abstinent, their PTSD symptoms actually get worse. And they do for a while, maybe for a long while. And again, so if we have that expectation that they're not going to be acting out, or this is, we just need to give them this treatment, that's not going to be enough. Yeah. Katie, I saw you nodding your head.
Yeah, I mean, I think, right, one of the things with trauma is that not everybody was, unfortunately, almost trauma is a human experience, and that almost all people have experienced trauma in their lifetime. And many people have experienced multiple traumas.
Yeah.
Not everybody develops PTSD, but part of the experience of trauma and related to PTSD is you're dysregulated, right? You're getting these intrusions, the worst parts of the memory are like, popping up at the times that you're unexpected. And so one of the strategies to regulate is to avoid. And many people use substances as that way to regulate, escape, and avoid. And that then can grow and grow and grow and become kind of an underlying problem. And so when people stop using substances, the underlying PTSD, peekaboo, right? Those symptoms, right? They need new strategies to regulate or treat those underlying symptoms.
Yeah, thanks, Katie. That is so true. It's why you might recall when I was talking about harm reduction in another group, if you were also in that group earlier this month, I said that people who are using substances, particularly problematically using substances, see their substance use as the solution, not the problem, because it's solving the problem. The problem is probably something like PTSD or some other more severe mental health issue underneath that is helping them. And so one of the first things that I say to people that I see in my office is sometimes to say, how about thanking the substances, because they kept you alive to get here. And now it's unfortunate that things have shifted in your relationship to that substance. So what would you like to do about that? Yeah, and there is a grief period that people often need to go through to understand how much that substance has supported them, has helped them in that way. And now it's not, now it's causing trouble. So there's that ambivalence. But now what do I do? I've used the substance for so long, I'm really scared that nothing else is going to work as well. Yeah, Lindsay.
I think so. I guess, and I kind of want to clarify what I put in the chat about so for me, being an organization that's trauma informed is going to look different for every single organization, right? Because trauma is going to show up different in different settings. And I think the best way that organizations can really navigate that is to have somebody that has gone through that, right? Has gone through their services and knows like how their trauma has been impacted, by the services, and have them be a part of like a steering committee. It's, I think, the best thing.
That's such a great suggestion. Thanks for bringing that up, Lindsay. And that's actually part of the organizational piece that I kind of skipped over, is looking at getting feedback from your patients and clients and really listening to that feedback. It doesn't mean that you can or should make every single change that they talk about. That's not going to be, possible in many cases. But again, since this is about being flexible, this is about learning and growing, just like an individual is going to, we're looking at it organizationally. What kind of things could we implement, or what kind of things could we try? One of the simple things that we did in the Prisoner Mother program that I was the clinical manager for, we offered a second group for all of our groups, or not all of them, for most of the groups during the day that the women needed to go through, so that they could choose. Would you rather go to this group or that group? I mean, just a small thing like that. And we didn't have the staff to do it for all the groups 5 days a week, but we could do some of the groups that way. And so that was the start. Yeah, so little implementations along those lines can really make a big difference. And also, I think part of what you talked about, Lindsay, was sort of having a point person in an organization that can be your trauma-informed expert if you want, kind of like we do with harm reduction or motivational interviewing. Have your champion there, as we call it in MI. And that's the person that can help you to kind of stay on track and let you know when you're getting off track, to take that feedback from clients and see how would this practically be implemented here in our program. Especially with opioids, I've had clients who want to not use them, but at the same time, if they don't, they can literally die. Yeah, absolutely. That's also true from alcohol. I think we forget that alcohol can be deadly if somebody stops immediately, depending on how much they've been drinking. And we know that alcohol is still a big influence in our country. I realize we're focused on opiates and not for a bad reason. That in our country, we tend to only focus on one drug at a time. I've always found that to be kind of funny because I was a poly drug user. I didn't know what it was to use one drug. And I'm not unusual. Most people are poly drug users. And that just means that I would drink and I would use other substances at the same time. But alcohol was always underlying it. And that's not unusual either. So again, looking at that, yeah. What else? Before we get to the case, any questions or comments? It always bothers me.
Yeah, Lindsay, it always bothers that we separate
Yeah,
mental and
Go
substance
ahead,
use.
Katie.
Yeah, I think that, there have been improvements around that revolving door where it's like, when somebody who's using substances shows up for mental health treatment, it's like, oh, go over there.
Wrong
but
door.
Wrong door, right? But it is an ongoing, effort to integrate, and there are some realities around limitations with expertise, staffing, that also make it hard. And, if we think about the different layers of influence, it's not that any of the organizations or any of our colleagues don't want to be trauma informed, that they don't want to provide holistic treatment, but there are often layers of restrictions that make these things harder to do.
Absolutely. Yeah, I used to hear a lot of times of people saying, well, we can't do that. And I'd hear a lot of the pushback on it was around, well, we're going to get sued. And I kind of love that. And then I started looking at lawsuits. And, California is kind of famous for all of our lawsuits. I think we have more lawyers than any other state. And so, looking at that and going, okay, we're pretty litigious out here. So how many lawsuits have there been specific to issues like this? And actually, there have been none. What there have been, though, are issues on the other side. So on lack of care, lack of being trauma informed, lack of giving options. Those lawsuits are winning. So I would make the argument that in reality, although I appreciate that it feels like maybe you could get sued for something. Sure, I mean, anybody can sue anybody for anything, let's face it. But the ones that are real are the ones where you're not providing as good of care as you possibly can, according to science, according to certain standards of care that we call evidence-based in this country, and things like trauma-informed, which is an evidence-based program or treatment. Sorry. Yeah.
Thank you so much, Dee-Dee, and for everyone.
The case now.
Yes, before we move on to the case, we have a few announcements.
That's right.
We want to go over. Taylor, if you can please share the slides. Thank you. Thank you so much. The Center for Substance Use Training and Telementoring offers technical assistance for various substance use disorder needs and topics through our team of experts. To request technical assistance, please complete an online request form and we'll be pleased to help you. Next slide. And to claim your CEU credits, you must complete the post-session survey in the chat or by the email sent after this session. Complete the post-session survey and select yes on the question, are you applying for CEU credit for today's ECHO session? Your certificate of completion will be sent to you 2 to 3 weeks after the session date. If you have any questions, please email bwelltexas@utesca.edu. Next slide. And there's an exciting virtual research opportunity through Be Well Texas. We are investigating the use of a therapeutic app meant to be used in conjunction with medication-assisted treatment for individuals with opioid use disorder. Please reach out to the contacts you see here for any questions or any additional information. The next slide. And we're excited to announce that the 2025 Texas Substance Use Symposium is officially open for registration. Register today at txsus.org to join us in person or virtually on February 27th to 28th. Next slide. And we are now accepting sponsor and exhibitor applications for the 2025 Texas Substance Use Symposium. To learn more, please visit txsus.org/sponsor Texas TXSUS. Next slide. And please join us January 31st for a special session on utilizing AI for behavioral health service delivery by Dr. Antoine. Thank you. All right, thank you. And we'll now move on to our case presentation for today. Mr. Cole, would you be able to share the case form and talk us through today's case?
Sure. You want me to share the form too?
Or we can share as well.
I mean, I don't mind. I just didn't.
Okay.
I can be though, very quickly. So, I'm pulling it up here.
Thank you.
You're welcome. All right. You should be seeing it now, I believe.
Yes.
All right. So, hey, everybody. Yeah, my name's Cole Watts. I'm a social worker here in the state of Texas, well, and Oklahoma too, I guess. And I represent a company called Stages of Recovery. We do substance use treatment and co-occurring disorders. We have a psychiatric mental health nurse practitioner on staff to kind of handle the medical mental health side of things. Should we have any prescriptions or other type of medical needs? So that's kind of a little bit of background about us. It's all outpatient treatment. We do have a housing program. They're mostly kept separate. But so yeah, that's a little bit about us as we go into it. We have our case today is about a 21-year-old male who is a Black or African American male. I actually think that he has mentioned being of mixed race identity, but he didn't share any other race other than Black or African American. His sexual orientation is heterosexual, and he didn't identify any cultural considerations when we were going through his assessment and stuff. But he does report that he has family support and he values spiritual practices, particularly like prayer, as a cultural consideration. So kind of a little bit about this client. I mean, I know there's questions. These questions are concerns. How can we effectively engage a client who exhibits depression-like behaviors and refuses to participate in treatment? And are there alternative strategies to addressing ongoing cannabis use in a client with poor impulse control? And then the next question or the next section actually describes the client in a little more detail. The client ultimately, you can kind of read some of those, but ultimately the client, although showing up to treatment and continues to verbally state in individual or intervention type, when we talk to him, whether it's in an official therapy appointment or not, He continues to claim his desire to want to be here and want to continue accessing treatment. He's not doing it out of he says that he's not doing it out of a sense of obligation to his family or to maintain some type of requirement in housing, because a lot of times sober livings will have that kind of requirement. There's no requirement there for that. So he's really, like I said, claims to be in treatment of his own accord, voluntarily, and really desires to continue with the outpatient treatment process.
Cole, sorry to intervene. Would you
Yeah.
be able to zoom in to the form a little bit so we
Sure.
can see the case?
Oh, there we go. That might help.
Awesome. That's super helpful. Thank you so much.
You're welcome. And so yeah, his behaviors don't necessarily back up those claims, right? Which is somewhat normal, I think, in most substance users, particularly in the first few months coming off of withdrawal and going through the honeymoon and peak cloud phase and into the wall. So he's got some, and plus for him, this could be depression on top of it. He is taking medications for depression. We'll get to that in a minute. But yes, so he's got some behavioral indicators of depression. Most of what he does in group therapy is he puts his hood up and he lays his head down on the table. And despite facilitator and peer best efforts to try to get him engaged, he usually just ignores them and pretends like they're not there. It's like as if nobody said anything to him at all. He did have a positive THC test a few weeks ago. And he didn't know what he said he smoked something at a vape shop. He wasn't sure what it was or the exact date or time of actually using it. But he thinks that could have contributed to the positive THC test. We have multiple locations. So after discussing with him and his family, he felt like it might be a good idea to have a change of location. So we moved him to the Waco location. It's a little smaller. And there's some younger people there in that location in Waco, just happened to at this point in time. Sorry. I'm gonna grab a tissue here. Forgive me. Got a handy napkin drawer right above my desk here. We moved him over to the Waco location because there's some younger folks there that we thought that are doing really well and motivated for recovery, like he says he is. And so we thought that would be a good support system for him. But even then, since moving towards the end of November, there hasn't been much change. There has been some minimal change though, but still he's kind of showing some of the same behavioral concerns maybe in treatment there in Waco. He also had we do this we track our clients weekly. They do a weekly assessment that does a bunch of different standardized assessment tools like the PHQ-9 and GAD and different stuff. And so one of them is, I could go into a bunch of detail, but it does 9 to 10 different standardized assessments, and one of them tracks their commitment. And his commitment dropped from a 92 to a 60 between October and November. And for reference, normally we want to see them in between 80 and 100. 80 and 100 on that commitment scale means that they're actually committed to the recovery process, whatever that means to them. It has nothing to do with any particular type of recovery. Anything from 80 to 60 actually is like, I still think that I could probably use a substance and do fine with my life. I don't need to be abstinence only. And then anything 60 or below is screw you. I just want to go get high. It's like that's what the track 9 people say. Anyway. So that's where we're at with him. He does have some goals. He wants to abstain from cannabis. That was his main drug of choice. He wants to increase participation in treatment activities. So he's showing the behavioral, decrease, but he's also wants that to be a goal of his, is to participate more. He's a very tall and athletic guy too. So he really wants basketball is a high pursuit of his. So that's a long-term goal of his, is to go to college and play basketball there. And then continue.
Hey, Cole, you've done such an amazing job with this write-up. And maybe what we could do is leave it up so people can read it. But I want to be mindful that we don't have a lot of minutes yet. And I want to come back to your question.
Okay.
Uh, One piece I want to ask about that was not explicitly clear. So we know that he's coming to treatment, but he's not doing anything. What has led him to come to treatment? Like, and he's had multiple hospitalizations.
Correct.
Yeah, tell us a little bit about that.
Ultimately, we don't really know outside of this right here. This is all he's told us is he wants to abstain from cannabis. I think ultimately he wants to, I think the big thing is he wants to go to play basketball in college, but he realizes that he probably can't do that using cannabis at the rate he was using it, if at all.
Okay.
But other
And
than
what do
that,
we know about the inpatient, the residential treatment, the 30-day treatment programs?
yeah, he's had, yeah, and he was successful in both of them.
And but what was the reason for attending them?
The same going for
Cannabis use.
like and I think most people stop in residential treatment first, whether they think they need to or not. So that's ultimately so this is his first participation in outpatient treatment. So every time,
Okay.
so the first two, or I think it might even been three times. There's two in 1 year, I think. But
Okay.
in those residential treatment times, he would go to residential treatment, he'd complete his 30 days, and then he'd go back to whatever family system I assume he was in at that time.
And so all related to his ultimate goal of abstaining from cannabis use. And do we know that using do we know for a fact that using cannabis is a barrier to going to college and playing basketball? Is that definitive? And
He
that's why there's an abstinence goal?
he claims it to be.
Okay, so in kind of from his point of view.
Correct. He claims that cannabis is probably the main thing holding him back from being successful in basketball, whether that's because of what it does to his body physically or because he doesn't think that he would be able to. I mean, I'm sure that I'm not totally sure, but I'm sure there's some states now where you could attend a college basketball program and you could use a substance like cannabis that's legal.
Possibly. Yeah, I'm not sure either, right?
It wouldn't
But
have any ramifications on your standing with the basketball team. I don't know. I would assume most collegiate basketball programs want you to abstain from cannabis use as well, but I don't know that to be true.
one
That's
last question, and then
He
we'll
knows more
open it
about
up.
that too. So I don't.
What, what is the function of the cannabis use for him? Like, why do you think, like, why does, even though he says he doesn't want to, right? And it's not aligned with the goals, like, what is it helping with? What is it doing for him?
Yeah, I mean, I would assume it has a lot to do with depression. I don't work with him individually, but I would assume it has a lot to do with his behavioral signs of depression.
Like the
Um,
cannabis use relieves those?
yeah, it probably exacerbates, but it also relieves. I would assume
Okay,
both. I would
right.
assume.
Okay, yeah. Lindsay, go ahead.
Yeah, so I guess I was just curious about you mentioned all the surveys that are those happening weekly? That seems to me like that would make me automatically not want to like if I'm getting asked that many questions every week, I would get tired of it. No offense. But I know that that's one thing that makes me withdraw from services. The other part of it is like for me, boredom, right? Boredom is a huge problem when it comes to things like that. So, and also kind of that culture of acceptance around marijuana. And so, really, I would be thinking about because we are trained, right? When I say when we are in services, right? We are trained that what it does the provider want to hear? They want to hear that we want to quit using, right? That's what they want to hear. So that's what we tell them, whether or not that's really our goal, right? So that might not be maybe exploring really in depth about like what and why that's his goal, what made him think about that or something around that. And then also I did notice too that the goals are really kind of like big. So breaking for me when I have a really low motivation, breaking them up into those SMART goals, the timely, all those things, sorry, that are small and achievable.
Measurable. Yep.
Yeah. I
Yeah.
have worked with somebody who her goal was to get out of bed 3 times a day at first because that's where she was, right? And then when that happened, yay! And then, kind of move on from there.
Yeah, I think that's great. One of the goals he has that we've kind of worked on, he's agreed to again. This is kind of, based on the fact that we're like trying to coach him through this process too, right? So he may just be saying what he thinks we want to hear. But one of his goals now is just to sit upright and participate in group, right? So yeah, but he doesn't do that, right? And that ultimately that would help to increase his participation in treatment activities, So I think you're on the right track for
Can I
sure.
ask you what participant mean? What does that mean to participate?
Thank you. That's what I was just going to throw in. I mean, in college, we've had to specify what participation means. If you're giving points for participation, let's say, right? So it might be attendance, but it also might be speaking up, or it might be, chatting on your chat somehow, or, whatever it is, to be as specific as possible for them.
Sure.
Let him perhaps come up with a couple of ideas.
Yeah, well, that was his idea. His idea was to just sit up, and to him, participating in group means sitting up and not having his hood on, which is fine. We're cool with that.
Crystal, go ahead. Thanks, Cole.
You're welcome.
So I was just curious because as you were scrolling down, I saw, so there's a lot of conversation around the depression and behaviors that indicate depression, right? But it's never been really diagnosed. But when you scroll down, I saw that he's on medicine for anxiety, right? And he had some traumatic things that he self-disclosed to your organization. And
Right.
so has anybody asked him if he's using the cannabis for the anxiety, or is everybody just focused on the depression, right? Because I mean, there could be a chance that the medicine he's taking is also making him slouch and be tired and put his head on, and he could be having other symptoms. Has anybody asked him?
Yeah, that's something we normally talk about. So the depression, he hasn't been diagnosed with depression. I checked yes. I almost checked unknown, but I checked yes on here just because of the behaviors that he's exhibiting. But when he's with our nurse practitioner, the only complaints that he has is around anxiety. And so, yeah, I'm sure that the cannabis use to him has a lot to do with his anxiety, and the medications that he's taking are directly for his anxiety. But we don't see any signs or symptoms of anxiety, nor does it show up on those track 9 scores on a weekly basis. Depression does. His PTSD, we also have him do the PCLC or PCL, whatever the citizen one is, right, for trauma. And there's no indicated trauma on a regular basis. He's not expressing consistent trauma scores, at least. I'm not saying it's not there. It's a good question, though.
Yeah, well, we're running out of time. One thing to, really think about is really like Lindsay and others have suggested, thinking about like realigning some of the short-term goals to things that are important in his life outside of treatment. He is coming, right? So we know he's coming, and that's important. And we've got this long-term goal of college and behave in basketball, but there's nothing that's necessarily meaningful to day-to-day life in the short term. And
You could see like his behavior totally changes when he plays basketball. Because we take him to play basketball, and it's like he's a totally different person when he's playing basketball. He's excited, he's happy, he's jovial, he's social, all these things that we're not seeing that he says he wants, right? Like, I don't care if you're social or jovial, or that doesn't matter to me, right? But those are things that he wants. And so it's cool to see it happening. So I know he has the capacity for it.
Yeah.
So how do we get him to do
and
it?
part of life long term is building out more opportunities to that.
Sure.
I'm sorry, I just got to throw this out there. One of the things I haven't heard, just from a cultural perspective, because it sounds like he has a fairly intact family, when they talk about the emotional abuse from both parents, has there been discussions about shame? It sounds like he's talented. He comes from probably a really intact family, and he has that prayer sort of spiritual space. Is there discussions about shame? Here's this guy that could probably go to college, play basketball, do really well, be successful, and he's doing something that's shaming him. He's shaming himself, him family. Has there been discussions about shame, guilt and shame as it relates to his use?
I'm not totally sure. I know there has been in group therapy, and whether or not he chose to participate in that is probably unlikely, I would assume. But in individual therapy, I couldn't answer that question. It'd be worth exploring for sure.
All right, thank you so much. I see that it's one. Thank you so much, everybody, for joining today's session. And as a reminder, to earn CEU credits, please complete the post-session survey using the link in the chat. And if you would like to present a case, please email us, the team. And we look forward to seeing you at our next session next year.
Happy holidays, everybody,
Yep,
whatever
and-
you celebrate.
Yes, and thank you.
you.